All right. So I think we are good to go now. Good. We have a 10-year-old child complain of weakness, nausea, irritability. Helminths of white color and 5 to 10 millimeters long were found on the underwear. Those who were with me on the microbiology. So anytime you find white helminth on the underwear, or when they say perianal scraping, perianal scraping, what comes to mind? Of course, Enterobins vermicularis comes to mind. Enterobins vermicularis, that comes to mind. And you can see on microscopy there's what scrape from the perianal folds. Perianal fold. So again, when you hear of underwear or some white helmet on the underwear, and then perianal folds, scraping from the perianal folds, and all those things, these things are revealing Enterobins vermicularis. Enterobins vermicularis. And so therefore, this is C. C. A patient has been brought to the hospital with a complaint of headache, pain in his right hypochondrion. He has been ill for 1.5 weeks. The sudden illness began with an increase of body temperature up to 39.9. In 3 hours, the temperature decreased and hydropoiesis began. The attacks repeat rhythmically in 48 hours. The patient had visited one African country. The doctor have suspected, so they're already suspecting what? Malaria. They're already suspecting malaria. And you know, malaria parasites or mosquitoes are endemic in Africa. They are endemic in Africa. So when people travel like that, they must get some vaccinations against this malaria, or they must give what we call prophylaxis against malaria infection. Otherwise, they stand a chance, or they are at risk of contracting this disease. So what method will you do to confirm your diagnosis? That's what they're asking. What method will you do? Normally we do what? Blood film, BF for MPs, or blood film for malaria parasite, MPs, blood film. So therefore, our answer here should be what? Blood examination. Some people will do what we call the rapid diagnosis test. That's RDT, or blood films, or blood examination. They are all the same thing. So here, your answer should be A. Slime, blood, and protozoa, 30 to 300 microns of length, have been revealed in a man's feces. The body is covered with cilia and has correct oval form with a little bit narrowed forward and a wide round-shaped back end. On the forward end is a mouth which is what? Visible. In the that is your clue. Your clue is this. In the cytoplasm, there are 2 nuclei, not nucleuses. It's 2 nuclei and 2 short vacuoles, for whom are the described attributes. I don't understand why they're even calling this as anatomy. This is not anatomy. This is microbiology, not anatomy. This question is microbiology, not anatomy. But then it's part of the base in anatomy. So I decided to tackle them as well. But we've done this already in microbiology. So 2 nuclei and 2 vacuoles. What do you think of? Of course, balantidiasis. And so therefore, the organism is called balantidium. So your answer is what? Is B. Balantidium. All right. A patient in 3 weeks after acute myocardial infarction has pain in the heart and joints and pneumonia. I've explained to you guys what myocardial infarction really talks about. Myocardial infarction simply means that the heart is undergoing what? Necrosis. That means there's inadequate supply of blood to the tissues. And so therefore, the tissue is going to necrosis, and that can lead to what? Pain. So they are saying after 3 weeks, of this infection, the patient has heart and then joint and pneumonia, pain in the heart and joint, and then pneumonia. What is the main mechanism of development of post-infection dressless syndrome? What is the main mechanism? Of course, even though I made you understand that in myocardial infarction, we are mainly talking about what? About ischemia or inadequate supply of blood to the tissue. But this is having a cause. They are talking about what? Dressless syndrome. Dressless syndrome. And the dressless syndrome, this is also known as the post-myocardial infarction syndrome. And it's the term that refers to, or it's an autoimmune infection. Autoimmune infection. Autoimmune inflammatory reaction as a result of the myocardial infarction. So when the MI is developing, when the myocardial infarction is developing, one way or the other, the body begins to see the cells as, as a foreign to itself. And so therefore begins to produce antibodies against its own tissues. And that phenomenon is called dressless syndrome. Dressless syndrome. So like I said, it's what? Post-myocardial infarction. So it occurs after myocardial infarction. So over here, we are looking more of what? Of an autoimmune inflammation rather than an ischemia. Rather than ischemia of the myocardium. But normally, in myocardial infarction, it is called by ischemia. But in post-MI, we are talking about autoimmune inflammation. So here, E should be your answer. During the fetal period of the development in the vascular system of the fetus, large arterial ducts, that's what the botalus or the arteriosus, ductus arteriosus, that's what they mean, is forming, which converts into ligament arteriosum after birth, okay? What anatomical formation that this that connect between each other? What it means is that ductus arteriosus or the ductus botali, what does it connect? What does it connect? Of course, it connects the pulmonary artery and the aorta. It connects the pulmonary artery and the aorta, the pulmonary artery and the aorta. So before childbirth, this arteriosus is opened, but after birth, within the first few weeks, it's supposed to close. But if it doesn't close, it then becomes what? A pathology. It then becomes a pathology. And why is it that it's always open when you are in the womb or before birth? Why is it always open? It is open because at that time, don't forget that pulmonary trunk supplies blood to the lungs, so that this deoxygenated blood from the pulmonary trunk will be oxygenated. So this ductus arteriosus helps the blood not to go into the lungs. Because as a baby, the lungs can't work. Or the lungs do not work. It's non-functional. It only begins to function after birth. And so therefore, it connects the pulmonary trunk to the aorta. So over here, we are thinking of what? E. E is our answer. A young man felt sharp pain in the back during an active tightening on the horizontal bar. Objectively, there is pain while moving up the extremity. Limited pronation and abduction functions. Sprain of what muscle is presented? Now, when we talk about abduction and adduction, we are talking about movement of, let's say, your arm away from your body laterally. when you are moving your arm away from your body laterally. It's called what? The abduction and the adduction. So when it goes and comes, we have the abduction, then adduction. We have A, B, D. Abduction or adduction. So there's two different things, up and then adduction. And how do I remember this? Add is like adding the arm to yourself or adding the hand to yourself. So that's like moving towards it. Then abduction, moving it away from your body. So an pronation is like turning it inside, turning your hand inwards. Okay, turning your hand inward from the shoulder level. Now they are saying that anytime you are doing all these things, there is pain. There is pain. There is pain. So definitely you are looking at a muscle that is around the, how do I even put this? You're looking at a muscle that is around the middle portion of your body. The middle portion of your thorax, let me put that way, the middle portion of your thorax or your body, your abdomen area. That is what we are looking at for. So here, what comes to mind is the latissimus dorsi. The latissimus dorsi. And this is a flat muscle on the back that stretches to the sides, behind the arm, and is partly covered by the trapezius on the back near the midline. Do you get it? So over here, we are looking at the latissimus dorsi. And those who go for gym, or those who gym, you realize that when you are pulling the metals down, like when you sit down and you are pulling the metals towards yourself, you are massaging or you are working on your latissimus. On your latissimus. That's when you finish and you raise your hand up, you can have that V shape. Aha. That V shape means that you have worked on your latissimus muscles. Good. That is it for because over here we are looking at the latissimus dorsi. The latissimus dorsi. All right. So here is A. Is A. Latissimus dorsi. Children often have heavy nasal breathing resulting from an excessive development of lymphoid tissue of the pharyngeal mucosal membrane or mucous membrane. What tonsils growth may cause this effect? What tonsils growth may cause this effect? Even if you don't know this, look at the fact that there's what? There's tonsil and there's what? The pharyngeal tissue or the pharyngeal membrane. Look at this, and over here, strictly put, you are looking at what? At a tonsillar pharyngea. Tonsillar pharyngea. Tonsillar pharyngea. How do you pronounce it? Tonsillar pharyngea. So over here, we are taking off what? Of A. So that's what the pharyngeal tonsil. Pharyngeal tonsil. That's just the name. Pharyngeal tonsil. Pharyngeal tonsil. So basically, that is just it. In the course of laparotomy, a surgeon revealed gangrenous lesion of the descending colon. It was caused by thrombosis of the following artery. Caused by the following artery. So now you ask yourself, where is your descending colon? Where is your descending colon? Don't forget, now assuming that, no, okay, let me just draw something for you guys. So at the time of this, you need a diagram to see it. So let's assume we have this. Let me do it double. Let's assume we have this. So this is somebody's large intestine, okay? This is somebody's large intestine, okay? So over here, we are having what? The ascending colon. Ascending colon, A. This is what? The transverse, T. This one here is the what? The descending colon. Then over here, we have the sigmoid colon. Then, of course, the rectum, the anus will now come in. So now, they are saying that now laparotomy means opening. So they have opened the abdomen. And they found out that there is a gangrenous lesion. When we say gangrenous lesion, we are referring to necrosis. We are referring to what? Necrosis. Necrosis. No, that means there's inadequate supply of blood to that tissue, and as a result, it is now beginning to undergo what we call necrosis, or simply put, ulcer or ulceration. Okay. So now they're saying that there is this descending what? Colon. So even if you don't know this, like you don't know the answer, think of the fact that this descending colon is found on the left side of your body. Yes, look at it. It is found on your left side, isn't it? So if it is found on your left side, that means we are talking about an artery or the colon artery of the left, or the left colon artery. Left colon artery. And in Latin or in Greek, the word left means sinister. Left simply means what? Sinister. Dextra means right. So over here, we are looking at what? The left colic artery. So A is your answer. Left colic artery. Left colic artery. As simple as that. So again, if they have talked about ascending order or necrosis of the ascending, what will you have thought of? Of course, you would have thought of what? The destra colic, or the destra colon artery, or the right colon artery. Then if they have spoken about the transverse, definitely you talk about the median colic, or the median or the middle colon artery, the middle colon artery, the middle colon artery. So these are the basic things that you need to understand when it comes to questions like this. Please know where the anatomy is, and easily you can find your answer. So the answer is A. 3 separate bones connected with cartilage in the area of the pelvis cavity are noticed on the X-ray of the pelvis. What are these bones? In other words, which bones form the pelvic, organ? The pelvic. Which bones form the pelvic bone? Which bones form the pelvic bone? And of course, you are talking about the iliac, the pubic, and then the sciatic bones. The iliac, the pubic, and then the sciatic bones. So over here, you are thinking of what? D. Iliac, pubic, and then the sciatic bone. Just get a bone. Unfortunately, there's no diagram to illustrate it, but just get the pelvic bone. Just Google it, get a pelvic bone. You will know what the iliac is, what the pubic is, and what the sciatic is. All right. So this is D. These organs form the part of the pelvic cavity, or the pelvic bone. So the answer is D. A 60-year-old patient has a reduced perception. Reduced perception. I think I've said this one over here. There's reduced perception of high frequency sounds. High frequency sound. What structures disorder of the auditory analyzer cause these changes? We have done this thing before. So high frequency, you are thinking of what? A problem that is near the oval window. That's high frequency. High frequency. Problem near the oval window. Then when they talk about low frequency, you are thinking of what? The apex, also known as the helicotrema. The apex, also known as the helicotrema. Then we'll talk about the median or the middle perception or middle frequency sound. Obviously, you are thinking about the middle portion of the helix, the middle portion or the middle part of the helix. But again, the whole organ that is responsible for hearing is called what? The organ of Corti. The organ of Corti. The organ of Corti. That is the receptor organ for hearing. And it is found inside the cochlea. It is found inside the cochlea. And sometimes they will talk about vestibulocochlear. Vestibulocochlear. All right. But the organ is called the organ of Corti. The organ of Corti. Again, high frequency sound deals with what? The cochlea that is near the oval window. The cochlea that is near the oval window. Low frequency sounds deals with what? The cochlea near the apex. In other words, helicotrema. Then for middle, we are talking about the middle part of the helix. The middle part of the helix. So again, over here, your answer should be what? Should be the D, the cochlea near the oval window. Cochlea near the oval window. All right. Okay. Now, the alveolar ventilation of the patient is 5 liters per minute. Alveolar ventilation of the patient. Okay, the breath frequency is 10 per minute. The tidal volume is 700. What is the patient's dead space ventilation? What is the patient's dead space ventilation? When we talk about dead space is the volume of air that is in the passageways. It is in the passageways and does not involve or get involved in gaseous exchange. That is the dead space ventilation. Again, it refers to the volume of air that does not get involved in gaseous exchange. That is it. Now, how do we calculate that? So to calculate the dead space, that is ds, the dead space. Dead space is equals to the amount of air that is involved in what? In ventilation. Sorry. Tidal volume, that is dV minus the dead space. This gives us the amount of air that is involved in alveolar ventilation. This gives us what? The alveolar AV, the alveolar ventilation. I repeat, the tidal volume minus the dead space should give us the alveolar what? Ventilation. Should give us the alveolar ventilation. Now, let's bring it back to calculations over here. Let's see how we can really calculate some of these things. And again, you can calculate the alveolar ventilation rate as the frequency times the alveolar volume. Frequency times the alveolar volume. But that is not it. I don't want to go into those things. But let's do some few calculations over here. So again, if you want to calculate the rate of this, then you just multiply this whole thing by what? By the frequency. You multiply this whole thing by the frequency. Again, tidal volume minus the dead space gives us what? The alveolar or the amount of air that is involved in alveolar ventilation. That's involved in alveolar ventilation. So let's do a little bit of what? Calculation. What is the tidal volume in this question? Tidal volume in this question is what? 700 mils. 700 mils. Minus what is the dead space? We don't know. ds, isn't it? Or it's equal to what? The alveolar volume is what? Alveolar volume is what? It's 5. 5 liters means 5,000 mils, isn't it? It means 5,000 mils. It means 5,000 mils. It's the same as 5 liters. It means 5,000 mils. And of course, they are saying the frequency rate is what? It's 10. So we can add the frequency rate to it as 10. So now the dead space, let's come up here. So now the dead space will be equals to, so over here we're talking about 5,000. You can do the calculation yourself too. 5,000, okay, minus 7,000. You know why I got the 7,000? Or divided by 10. I will show you why. Now multiply 10 by 700. That is 7,000. Then multiply what? 10 by, how do you call it? The dead space. That is 10 ds. This is giving us what? 5,000. Isn't it? Don't forget, this one should be what? Negative, because this is negative here. So this is what? Negative. This will be, hold on. Negative, yeah. So now it's 5,000 minus 7,000. This is negative 2,000. So we have negative 2,000 divided by what? 10. Isn't it? So now we have what? Negative 200. So it means that ds is equal to what? 200. ds is equal to what? 200. 200. 200. 200. 200. So that should have been the answer. 200 mils. 200 mils. 200 mils. But unfortunately, Krok says this is what? 2 liters. 2 liters simply means what? 2,000. But it's not up to 2,000. This is supposed to be what? 2 liters. Sorry, 200 mils. That is 0.2 liters. But over here, Krok says your answer is D. Krok says your answer is D. Your answer is D. So maybe they thought, maybe they didn't divide it by the 10. That's why they had the 2,000, isn't it? They didn't divide by the 10, they had the 2,000. So basically, your answer is what? Is D. But it's supposed to be what? 0.2 liters or 200 mils per minute, of course. All right. Now, sorry. During investigation of a patient, it was found formation in the white substance of the cerebral hemisphere with location in the knee and the frontal parts of the posterior crus of internal capsule. Fibers of what conductive tract of the brain will be disrupted. So over here, they are looking at what? At let me say a tract, okay? A tract that can be found where? In the cerebrum or in the cerebral hemisphere. Then it moves to the what? To the knee and the front part of the internal what? Capsule. Unfortunately, we don't have how do you call it? A diagram. I don't have a diagram to illustrate the movement of this tract for you. But basically, we are dealing with what? The pyramidal tracts. The pyramidal tracts. We are dealing with the pyramidal tracts. And I will encourage us to just find time and then look for a diagram of the pyramidal what? Tract. And then you will see the connection between or what tract sensory or motor fibers from the cortex to the internal capsule. The internal capsule. This is anatomy, so unfortunately, I cannot be able to illustrate it because of the fact that it's not here, or I didn't put it here. So over here, we are looking at what? At C, pyramidalis. But I think for the sake of questions like this, I should be doing diagrams, or I should bring a diagram so you people can also what? See and then get a better understanding. So perhaps maybe from part 2 going, when I see that anything involves a diagram, I will try as much as possible to let you guys see how it looks like or how it is. All right. Only one factor can influence the charge of amino acid radicals. Only one factor. What are you talking about? You know, every enzyme must work under a specific what? pH. Every enzyme must work under a specific what? pH. Although pressure and temperature all play a role, and of course, inhibitors all play a role in the proper function of an enzyme. But in all, pH is mostly used, or that's what we are going to really concentrate our mind on. The rest can, like I said, pH will be more ideal. pH will be more ideal. pH will be more ideal. So your answer is A. pH medium. Succinate dehydrogenase catalyzes the dehydrogenation of succinate. Malonic acid is used to interrupt the action of this enzyme. Choose the inhibition type. Look at it. They are telling you that this enzyme is converting what? This, or is catalyzing the dehydrogenation of succinate. And now they have brought in malonic acid to come and interrupt this enzyme. So what does it mean? It means they are looking for what? A competitive what? Inhibition. Competitive what? Inhibition. So this will come and block the action of the other one. Isn't it? So over here, we are looking at what? At a competitive what? Inhibition. A competitive inhibition. So this one is what? The answer is E. The answer is E. And when we talk about the competitive inhibition, it is an inhibitor that resembles the normal substrate it resembles the normal substrate that binds to the enzyme. And usually it affects the active site. You know, the active site is where, how do you call it? The active site is where enzyme activities, becomes very, very profound, isn't it? So when these people go and bind at the active site, what happens? It means that it is mimicking the action of what? The original enzyme. But here's the case, it is not. It is not the original enzyme, but the body sees it as what? The original enzyme. So when it tells you, please stop, it will stop. Great. So over here, we are looking at what? At a competitive. So the answer is E, competitive. All right. Gluconeogenesis, that is the production of what? Glucose from non-carbohydrate materials, is activated in the liver after intensive physical training. Physical training. When you do physical exercise, what happens? You hear that there are a lot of what? Muscle pains. These muscle pains are as a result of accumulation of what we call what? Lactic acid. Lactic acid or lactate. Or lactate. Or lactate. So they're asking us what substance is utilized in gluconeogenesis, first of all. Of course, we are looking at what? Lactate. 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 All right. A patient with a stab wound of the anterior stomach wall is in surgical care. What formation of the abdominal cavity did the stomach content get into? Now, you must understand that there are some cavity that surrounds the stomach. Usually we call them what? Basas or basa. We call them basa. And then 3 basa can be found at the superior level of the peritoneal what? Cavity. 3 basas can be found at the superior level of the peritoneal cavity. These are hepatic basa, pre-gastric basa or antigastric basa. Then we have the omental basa. Okay. Now, take note. I'm going to describe each and every basa and how the neighboring structures are close to it and their neighboring structures. Okay. So again, we have what? 3 basas at the superior level of the peritoneal cavity: hepatic, pre-gastric or antigastric, and then we have what? The omental basa. Now let's look at the walls of the antigastric basa. Let's look at the walls of the antigastric basa. Medially, we have the falciform ligament. Example, something like this, I need to show a diagram, but unfortunately, there's no diagram. Antigastric basa, like I said, medially, we have the falciform ligament. And posteriorly, we have the anterior wall of the stomach. Guys are listening? Posteriorly, we are having the anterior wall of the stomach. Great. Then we have what? The lesser omentum. And superiorly, we're talking about what? The lateral and the anterior peritoneum. Lateral and the anterior peritoneum. Then with the pregastric basa, it is found, or the pregastric basa is found at the anterior to the stomach. It is found at the anterior to the stomach. So what it means is that anytime you put a stab or there's a stab wound at the anterior portion of the stomach, what happens? It means that this pregastric basa or this antigastric basa could be what? Affected. Could be affected. So that is where the content of the stomach will eventually get into or drain into the antigastric basa. The antigastric basa. So over here, you are looking at what? Anti-gastral buzzer. Anti-gastral buzzer. So here, we are talking about what? About A, anti-gastral buzzer. Now, with the omental and the hepatic, as the name is telling you, it deals more with what? For hepatic, it deals more with the liver. So it is closer to the liver. So if there's an injury, perhaps to the liver or something like that, what buzzer can be affected is the hepatic. Or these things will drain into the hepatic buzzer. And the omental buzzer too, the same way. Now, after the stomach, if anterior to it, we can have the omental what? Buzzer. We can have the omental buzzer. But over here, our focus should be on what? On the anti-gastral buzzer. Even if you don't know, the name alone should tell you that that should be more ideal. The anti-gastral buzzer. All right. A patient has been taking glucocorticoids. A patient has been taking glucocorticoids for a long time. And you know, glucocorticoids are produced by the adrenal gland. By the adrenal gland. The last time I showed you guys GFR, isn't it? GFR. I'll show you guys GFR. Glomerulosa, fasciculata, reticulata. This is the part that produces cortisol. Cortisol. This part produces what? The aldosterone. You know it has 3 layers or 3 zones. The aldosterone. Then this layer produces what? The sex hormones. Please take note. And all of these are part of what? The adrenal cortex. So the question now is that since he has been giving glucocorticoids for a very long time, what happens? When the preparation was withdrawn, in other words, they stopped giving this drug. There was now what? A decrease in blood temperature, weakness, and aggravation. What is the reason? Of course, the reason will be that there is what? Adrenal gland insufficiency or low production of what? Cortisol level. That is why this patient is reacting to it or is becoming what? Aggressive, and the blood pressure is reducing. So over here, we are looking at what? The appearance of adrenal insufficiency. The appearance of adrenal insufficiency. Insufficiency. Now, if they say hyperproduction, this can lead to what? Increased production of what? The aldosterone rather, not a decreased production. Not a decrease, but whatever, an increased production of the cortisol, sorry, of the cortisol. Of the cortisol. All right. So this phenomenon is called the Addison disease. Just to add up. A patient has tissue ischemia. Tissue ischemia. Again, when we say ischemia, means what? Inadequate supply of what? Blood. Good. Below the knee joint, okay, accompanied with intermittent claudication. What artery occlusion should be suspected? Guys, look, the knee joint. So you ask yourself, what artery can be located around the knee for which its occlusion is causing this claudication? And what comes to mind? Of course, the popliteal artery. The popliteal artery. And this is a continuation of the femoral artery. It's a continuation of the femoral artery. But this one is more around the knee joint. It's more around the knee joint. So over here, you are thinking of what? The popliteal artery. The popliteal artery. Of course, tibial artery deals with what? With the tibia bone. Femoral artery will deal with what? With the femoral bone, of course. But here is the knee, so popliteal bone. Sorry, popliteal artery. All right. A patient who suffers from congenital erythropoietic porphyria has skin photosensitivity. The accumulation of what compound? The accumulation of what compound? So normally when we have a congenital erythropoietic porphyria, this is actually a metabolic or an inherited metabolic disorder resulting in a deficiency of the enzyme called uroporphyrinogen 3 co-synthase. Uroporphyrinogen 3. Uroporphyrinogen what? 3 co-synthase. 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 However, its isomer is uroporphyrinogen what? 1. Profinogen what? 1. Profinogen 1. So over here, your deficiency or what compound it is being produced or is there is what? Is the uroprofinogen 1. The uroprofinogen 1. Not coprofinogen 3. It is what? Uroprofinogen 1. So over here, you are thinking more of what? Of D. You are thinking more of D. And these people, they become what? Hypersensitive to sunlight and even some types of artificial light. And when such happens, they begin to have what? Blisters on the skin. Blisters on the skin. And sometimes it can lead to hyperpigmentation if the exposure is very long. Hyperpigmentation. All right, so over here, we are looking at what? Uroprofinogen 1. Like I said, it is an isomer for uroprofinogen 3 co-synthase. All right, so these are two different things. So the answer is D. A patient has a malignization of the thoracic part of the esophagus. The thoracic part of the esophagus. What lymphatic nodes are regional to this organ? What lymphatic node are regional to this organ? Again, you need to understand the anatomy of these lymphatic nodes before you can be able to know. But basically, we are talking about the annulus lymphaticus cardi. The annulus lymphaticus what? Cardi. And this refers to what? Lymph nodes around the cardia of the stomach, under the lymph node. Now, don't forget that the thoracic part of the esophagus is usually entering the stomach. Don't forget that the thoracic part of the esophagus normally end up entering what? The stomach. And the first part of the stomach is the what? The cardiac part. Then we have the fundus, the body, then the pyloric part. These are the parts of the stomach. So we can basically say that this one here is suffering from what? The cardiac part. So even if you don't know, think of the stomach as a clue. Think of the stomach as a clue. And again, the initial part of the stomach is called what? The cardiac part or the cardiac part. All right. So your answer is what? Is D. D. The patient has come to the hospital from the smelting workshop in a condition of hyperthermia. Hyperthermia. That means quite hot, isn't it? What is the direct cause of loss of consciousness at the heat stroke? At the heat stroke. So the person is having what? Hyperthermia. 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 And as a result, we're having what? Loss of consciousness. Loss of consciousness. So what could be the cause? And over here, wait a minute. Aha. What could be the cause? There's hyperthermia. That means blood is becoming what? Quite hot, or the body is becoming what? Quite hot, and there's loss of consciousness. Definitely, there's a shift of what? Of blood or blood supply. You know, stroke, you get stroke when you don't have what? Inadequate what? Blood supply. When you have inadequate blood, that's when you get what? Stroke. So this stroke can either be what? Be hemorrhagic stroke or what? Or ischemic what? Stroke. So over here, there is inadequate supply of blood to the brain. So this is called an ischemic what? Stroke. And why is there inadequate supply of blood? Because of what? The hyperthermia. So all the blood are moving away from the brain. So over here we have what? A decreased blood to the brain. Decreased blood to the brain. So the answer is E, decreased blood to the brain. A patient's blood was analyzed and the decreased erythrocyte sedimentation rate was discovered. ESR. That means the ability of the erythrocyte to sediment or to be sieved or to be sedimented. What disease from the listed below is accompanied with a decreased erythrocyte sedimentation rate? And you are thinking of what? Of course, polycythemia. Polycythemia. Polycythemia is simply a disease state in which the hematocrit is elevated. The hematocrit is, when we say hematocrit, we're referring to the percentage of the red blood cells in the blood. So in polycythemia, it occurs when the hematocrit is increased. Now, again, to an increase in the number of red blood cells, which is definitely mean cythemia, causes a reduce in the erythrocyte segmentation rate. Why? Because the viscosity of blood will increase. So imagine you want to make some substances settle down in an experiment you're making, something to settle down, for instance. Now, if the fluid is thick, it will take time for the sedimentation to take place, isn't it? The same way applies to blood. If the viscosity is thick or is high, that means there will be the decrease in its sedimentation. It will take time for it to settle down. And that was saying this is what polycythemia. There's too much red blood cells inside the blood. And so therefore, it takes time for it to settle down. Why? Because increase in viscosity. Increase in viscosity. So over here, we're looking at what? Polycythemia. Polycythemia. All right. 55-year-old patient was hospitalized as a result of trauma to the medial group of the femoral muscle. What kind of movement will be unable to do? What kind of movement will be unable to happen or to do? So what comes to mind? So here we're talking about the femoral muscles, the medial group of the femoral muscles. And then, so these are the muscles in the medial compartment of the thigh. In the medial compartment of the thigh. And these are responsible for hip abduction. For hip adduction. 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 Not abduction. Adduction. So that is the movement that is going to be impaired. So we're talking about adduction. Adduction. The answer is what? Is E. Adduction. All right. A mother of a newborn complains of her baby's constant belching with undigested milk. What developmental anomaly is this evidence of? Now, if the patient is belching and cannot digest milk like that, there could be what is it called? The esophageal atresia, isn't it? There can be esophageal atresia. And esophageal atresia is simply what? A congenital medical condition that affects the alimentary canal. It affects the alimentary canal. And it doesn't help food substances to be properly absorbed or enter very well for its absorption. So therefore, over here, we are looking at esophageal atresia. Esophageal atresia. The answer is B. All right. During the endoscopy, the inflammation of the major papilla of the duodenum, okay, and the disturbance of the bowel secretions were found. Again, there's what endoscopy revealed a major papilla of the duodenum and the disturbance of the bowel secretion were found. In which part of the duodenum were the problems found? In which part of the duodenum were the problem found? Which part of the duodenum? Of course, you see, when I have your duodenum, let me try and see if I can do something like this. So assuming this is your duodenum, okay? Your pancreas is somewhere here, isn't it? Then it opens, that's what's called the ampulla, okay? Then we have the papilla. All of them start joining in to the duodenum. So this is what? Descending, isn't it? It is descending. So we call it what? The descending part of the duodenum. Descending part of the duodenum. So that is what happens. the descending part of the duodenum. So here you are looking at what? At B, the descending part of the duodenum, descending part. All right. An 18-year-old patient came to the outpatient department with complaints of bleeding trauma in the vestibule of his nose. On examination, mechanical injury of the mucous layer of the vestibule was without continuation into the nasal cavity proper. What is the boundary between the vestibule and then the cavity proper? What is the demarcation or the boundary? Of course, you are looking at what? The nasal limen. The nasal limen. Now, the nasal septum is what is in the middle that you can always see from the left and right nose. That is what? Septum. The conha are the let me say, the openings or the meatuses. The meatuses. Those are what the cones, whatever they call it. Then the nostrils, of course, you know your nostril. But over here, we're talking about the nasal limen. The nasal limen. The nasal limen. Don't forget, the nasal cavity is just an air-filled space in the middle of the face, or the nose in the middle of the face, basically. And again, the septum divides the cavity into two cavities. Basically, that's just it. So over here, we are looking at what? The limen. A 32-year-old patient has been diagnosed Botulinitis. That's inflammation of the Botulin gland. In which part is it found? Of course, it's found in the lips. But which part of the lips? The larger lips or the greater lips or the major labia? Lips is called what? Labia. The lips is called what? The labia. Ladies will understand this more than the guys anyways. So it's the lips of the vagina. Okay, the lips. So the major one or the greater lips. So your answer is what? Is B. Is B. This is a gland. It's a gland actually. It's a gland. It produces some mucus that helps, sometimes you see some few oily stuff. That's because the Botulin glands are working. All right. A 50-year-old patient had hemorrhage of the brain and was taken to the hospital. The place of hemorrhage was revealed in the lateral hemisphere. During a medical examination, what artery was injured? Now, if we talk about the cerebral hemisphere, the arteries that are mostly injured are the middle cerebral arteries. These are the arteries that are normally what? Injured. And it supplies the lateral surface of the brain and the temporal lobe. It supplies the lateral surface of the brain and the temporal lobe. So over here we are, and this forms part of it's the largest branch of the internal carotid artery. And we know internal carotid artery supplies blood to the brain as well, isn't it? So these arteries could be damaged. So we're looking at what? The cerebral artery. So E, the middle cerebral artery. A 30-year-old patient was hospitalized due to bleeding of the facial artery. What place on the face has to be pressed to stop this bleeding? So first of all, you must understand that the facial artery arises from the external carotid artery near the angle of the mandible. And it runs the posterior edge of the lower jaw and curves upward over the outside of the jaw. Then it now passes through the cheek to the angle of the mouth. What it means is that if you apply a pressure at the mandibles area or the mandibles edge, what happens? Bleeding will stop. So over here, you apply pressure at the mandibles what? Edge. The mandibles what? Edge. So over here, we are looking at what? At A. The mandibles what? Edge. Like again, like I said, the external carotid artery, it is near the angle of the mandible, the edge of the mandible, before it starts moving upwards into the face. So here we're looking at what? At A. A 19-year-old patient was diagnosed with appendicitis and was hospitalized. The surgical operation on ablating the appendix vermiformis is to be performed. What surgery must be fixed to stop bleeding during surgical operation? During surgical operation. Don't forget, an appendix is there. So over here, we are going to look at what? The artery that is supplying what? The appendix, isn't it? Or the artery that has a connection with the appendicular artery, or that anastomosis with all of these arteries. And over here, you are thinking of what? The ileocolic artery. The ileocolic artery. Now, today you won't talk about the sinistra, the destra, because this talks about the colon, isn't it? Aha. So over here, we'll do more with what? With the ileocolic artery. Now, the ileocolic artery is just the lowest branch arising from the superior mesenteric artery. It passes down and to the right behind or towards the right iliac fossa. So when you say the right iliac fossa, we're referring to the right lower quadrant. Your right lower quadrant. Your right lower quadrant. This is where it divides into what? Into the superior and the inferior branch. The inferior branch arises to or gives rise to the appendicular artery. It gives rise to the word appendicular artery. And don't forget, the appendix is at where? At the right iliac region. The right iliac region. Good. So, if this ileocolic artery is pressed or is fixed, that means bleeding can be stopped. So over here, we are looking at what? At ileocolic artery. Ileocolic artery.